Hi, I'm Conrad Fisher, Associate Professor of Medicine, Pharmacology, and Physiology at Touro College of Medicine, the largest medical school in the United States. And this modality is unquestionably the best thing that you can do to bump up your Step 2 grade on your exam. But in addition to that, I want to emphasize that there is nothing superficial in this modality. You will be crisply current. You will be totally state of the art for your rotations. This will prepare you both for your shelf examination and for any examination you have to take during your third or fourth year of medical school in internal medicine. So you can be 100% certain that you can take everything in this section and memorize it. In the pituitary section, we'll be covering panhypopituitarism, deficiency of the posterior pituitary, which is diabetes insipidus, acromegaly, which is growth hormone excess, and hyperprolactinemia. As we start the endocrine section, I would like to be 100% clear you can take everything we're doing here, not just for your Step 2 examination, but you can take care of patients. This is 100% accurate for real day-to-day patient care in addition to your examination. Now, panhypopituitarism is most commonly caused by compression or damage of the pituitary gland. Now, the etiology of that compression or damage doesn't matter that much from the point of view of the output of the pituitary. Any tumor, cancer, adenoma, cyst, meningioma, craniopharyngioma, or lymphoma, anything that presses mass effect. The pituitary is a very small gland, and it's not got a cartilaginous ring like the bronchi. Any additional pressure on such a tiny, squishy gland will result in a loss of function, particularly of the anterior pituitary hormones. That's because those hormones are made in the anterior, and they simply cannot be produced if they are markedly compressed. Trauma and radiation are also damaging, because if the cells are simply killed off, they can't produce the hormones. The posterior is different. The posterior hormones are made in the hypothalamus. They're simply stored in the posterior pituitary. But the anterior pituitary hormones are not just stored there, they're produced there. Look at this terrific picture of the hypothalamus and the third ventricle. And it's hard to appreciate, but that pituitary stalk is extremely small. It's extremely thin. It's very delicate. It's easy to compress, to damage, to cut. We're going to make it today so that you are able to completely understand that the releasing hormones come down from the hypothalamus. They go into the anterior pituitary. And then the growth hormone, prolactin, TSH, ACTH, LH, FSH are all actually produced in that anterior pituitary. In addition to trauma, we also have things that can replace the gland. Iron in your head. It's part of the reason you get infertility with hemochromatosis. The iron actually replaces the anterior pituitary. Those granulomas of sarcoid replace the anterior pituitary. Histiocytosis X is another granulomatous disease that could damage the hypothalamus and the pituitary. And any infection, but of course, large infections like TB, fungus, parasites, or an occasional autoimmune damage where antibodies attack the pituitary or lymphocytes attack the pituitary and cease function. It's a very delicate organ. Prolactin deficiency is essentially asymptomatic in all men all the time, and it is asymptomatic in women unless they've given birth and want to lactate. Now, prolactin, you'd be amazed that I was over the age of 40 before I realized that prolactin meant it was in favor of lactation, and progesterone was in favor of promoted progestation for gestation in the placenta. But that's all it is. You see, if it's deficient, you can't lactate. So therefore, most people will never notice a prolactin deficiency because it is under tonic inhibitory control. It's inhibited most of the time by what's called prolactin inhibiting factor, or simply dopamine as it comes down out of the hypothalamus. Of course it's inhibited all the time. Why would you want to make milk when you don't have a baby there to drink it? luteinizing hormone, LH, and follicle-stimulating hormone, FSH, when they're deficient. Well, if you are a postmenopausal woman or an elderly man, you may not even notice these, because as long as you don't mind living without your testosterone or estrogen, you don't particularly need it. They're not essential for life. Both genders would have a decreased libido, decreased axillary, pubic, and body hair, and men would have a decreased ability to produce both testosterone and sperm and erectile dysfunction. And remember, testosterone also makes manly man muscles. That's why professional athletes are tempted to use just a little more than they're supposed to. And if you're a person who is not sexually active and elderly, and you have been postmenopausal anyway, such as in a woman, you may not notice that specifically, beyond, say, a generalized loss of energy. A woman is unable to ovulate or menstruate, so therefore, in a premenopausal woman, it would be distinctly noticed as missing your periods. Growth hormone is not a really good name for the hormone in an adult. You see, in an adult, what is growth hormone doing in you today? What is the function of growth hormone in the post-pubertal person? And the answer is, not very much. See, in adults, it's a stress hormone. In adults, you rarely miss it because you have 3 other stress hormone systems. You have, harken back to the days of your step 1 preparation. Glucagon, cortisol, catecholamines. So since you have glucagon, cortisol, and catecholamines, you generally won't notice a growth hormone deficiency. When you're studying, and I think everyone should look at multiple books, you may see some people talk about, wrinkles and a little low energy. But the truth is that the majority of the time, if it was just growth hormone deficiency, you wouldn't even notice it. Now, in a child, in a prepubertal, there'll be dwarfism because you need it for bone and muscle formation. But in adults, you don't notice it. Look at this. Catecholamines, glucagon, cortisol have stress hormone function. They raise the glucose. They raise the fatty acids. You see, in an adult, growth hormone doesn't cause growth anymore. You could call growth hormone the baklava hormone because it provides you a sudden surge of sugar and fat that helps give you a little energy. But you wouldn't die without baklava. Kalman syndrome is a genetic disorder where the person has a decrease in FSH and LH. Because there's a decrease in FSH and LH, you don't make the hormones of sex hormone, of testosterone or estrogen. It is a gonadotropin-releasing hormone deficiency, and it's associated with anosmia. Now, embryologically, it's very interesting. It has to do with the fact that the olfactory lobes don't migrate to the right position when the hypothalamus is formed. But on a step 2 exam, you really don't have to study anything more than what we just said in this tiny little slide. It might be hard to believe that's all you need. Hypogonadal guy with decreased ability to smell, decreased FSH and LH. In addition to the deficiency syndromes of individual hormones, hyponatremia occurs because low thyroid results in decreased free water clearance. Hypothyroidism is like pseudohyponatremia, psychogenic polydipsia, and SIADH as a cause of hyponatremia with normal volume status. There's glucocorticoid underproduction, and potassium levels tend to remain normal because aldosterone is unaffected, and it's aldosterone that excretes and maintains the potassium. So overall, you will notice a low thyroid and low glucocorticoids. Those are the 2 that must have mandatory replacement when your hypopituitarism occurs. In the center of this MRI is a white lesion that is showing a compression of the pituitary. This MRI is detecting a mass lesion compressing the pituitary and shows you how distinct the pituitary can be on an MRI. Growth hormone is first detected with an insulin-like growth factor level, IGF level, and that's because growth hormone is maximum in the middle of the night. So it is not convenient to test a hormone that has a very short half-life and is only released in the middle of the night. So therefore, the best initial test for all growth hormone abnormalities, whether high or low, is an IGF level. A testing of deficiency of growth hormone production is difficult. There are two ways to do this. One is you give arginine, and arginine should normally increase growth hormone. That would be the normal finding. If you give arginine that doesn't increase growth hormone, you have an insufficient production from your pituitary. Now, this is based on the fact that growth hormone helps proteins grow. So if I give you an amino acid like arginine, it should stimulate it for two things. One is for gluconeogenesis. The other is so it will produce IGF and help you make those proteins. Growth hormone releasing hormone stimulation is also useful because, again, a normal response would be an increase in growth hormone. ACTH and cortisol levels, high or normal levels, exclude panhypopituitarism. The problem that you have is that when the levels are low, you can't tell if you're in the normal trough of a diurnal cycle or whether or not somebody has a real panhypopituitarism. Sex hormones start out with LH and FSH and testosterone levels. And if these are elevated, an elevated level of any one of these tells you it's simply not panhypopituitarism. The problem is that these levels are all made in pulsatile fashion. Since they're made in pulsatile fashion, you can't tell if they're low. A low level doesn't mean you have panhypopituitarism. A high level excludes panhypopituitarism, and it is the same with TSH. A high level excludes. Occasionally used tests for panhypopituitarism would be metirapone. The metirapone test is a very difficult to understand test because what it basically is doing is inducing an 11-beta-hydroxylase deficiency. See, metirapone inhibits beta-hydroxylase. Well, beta-hydroxylase is necessary to produce cortisol. So if you don't produce cortisol, well, how does it test your pituitary? Well, what acts as the feedback inhibition upon the pituitary except cortisol? Well, nothing. Only cortisol inhibits ACTH. So if you had a person who's 11-beta-hydroxylase deficient and low cortisol, the ACTH level should be, a normal person, it should be up. If you have an ACTH and 11-deoxycortisol level that rise, it means that you have a normal person. If I shut off cortisol, a normal person should rise up their ACTH to stimulate the adrenals. If you give metirapone and ACTH level stays low, your pituitary is not working. Insulin stimulation has been largely discontinued because it's dangerous. A normal person, when you have a decreased glucose level, has the pituitary that makes lots of growth hormone. But if you don't rise the growth hormone level, if the growth hormone fails to rise in response to insulin, it indicates pituitary insufficiency. A normal person, when they get hypoglycemic, should make more growth hormone. A person with panhypopituitarism will not. You replace deficient hormones with thyroxine, cortisol, and sex hormones. These are the ones that are most essential, and they're given to you in the orders of the most absolutely essential. Thyroxine is by far the most absolutely essential. You don't have to replace growth hormone in adults because growth hormone is just one of the stress hormone systems. ADH and oxytocin generally don't need to be replaced just for pituitary insufficiency because, one, no deficiency disease is described for oxytocin because oxytocin just helps uterine contraction during delivery. But since delivery still occurs even if it's absent, you don't need to replace it. ADH deficiency, which is central diabetes insipidus, doesn't have to be replaced because, frankly, the hypothalamus just takes over releasing the ADH directly. It's kind of like buying books from Amazon. If all the bookstores shut, you just get it directly from Amazon. Diabetes insipidus is a decrease in the amount of ADH from the pituitary at central diabetes insipidus, or in a decrease in its effect on the kidney, which is nephrogenic diabetes insipidus. Now, central diabetes insipidus almost exclusively happens from damage to the brain, from a stroke that kills off those cells, tumor that kills off the cells in the hypothalamus, trauma that kills off the cells in the hypothalamus, or hypoxia, things that infiltrate the hypothalamus or kill it off